Next, I'd like to introduce Dr. Sophia Yen. She's a clinical assistant professor in the Department of Pediatrics at Stanford / Packard Children's Hospital, and her area of interest and expertise is in adolescent medicine. She did her medical training at UC San Francisco, residency at Children's Hospital in Oakland, and fellowship at UC San Francisco. Dr. Yen.
So this is a different tact, and I'm going to go over a contraceptive update, EC IUDs, and no more periods. So kind of a potpourri. And I too have a billion slides that I need to cover in 15 minutes. So the goal, hopefully, that you'll walk out with today is that you'll know everything there is to know about emergency contraception. The key thing is that you can use it up to 5 days after contraceptive failure or rape, and that we need to tell men about it, because if the men don't know, the men won't fess up when the condoms pop. Ulipristal, 30 milligrams. It's a prescription-only emergency contraception, so you hear a lot of talk about over-the-counter of emergency contraception, but Ulipristal and the copper IUD for emergency contraception are actually far more efficacious. So if it were me in the ER raped or my daughter, these are the medications that I would ask for rather than the over-the-counter option. On a separate note, in terms of contraceptive update, the latest thing is that IUDs are good. IUDs are okay. And we really, really strongly recommend IUDs in younger women, because who else would you want to prevent pregnancy in for the next 5 to 12 years? Somebody heading off to college, somebody heading off to med school, somebody heading off to law school. Something you stick in, don't worry about. And then when you want to get pregnant, take it out, then get pregnant. And that menstruation should be optional. So that's my crazy feminist idea, but I'll present the case to you. So emergency contraception, there are various methods of emergency contraception, and if you go from the left, this is the least efficacious. The old days, pop 4 birth control pills now, and pop 4 in 12 hours. More efficacious is the over-the-counter levonorgestrel only methods, Plan B, Plan B one-step, next choice, and then, as I mentioned earlier in my talk, Ella, which is prescription only, and the copper IUD, which is also only a physician or medical provider should be inserting that. So just to show you the difference in efficacy, at 0 to 24 hours, Ulipristal, again, the prescription only, has 0.9% pregnancies versus the levonorgestrel Plan B over-the-counter, 2.5%. If you look at it at 0 to 72 hours, 1.4 to 2.2, and 0 to 120 hours, 1.3 to 2.2. So every single time period, Ulipristal acetate outperforms. So if it were you in the ER, or your daughter, your niece, or your granddaughter, which medication would you go for? Ask for the Ulipristal. The physician may not be educated, may not be up to date, so you need to know this, and you need to ask for it. And they may know, but maybe it's not available in their pharmacy or something like that. The copper IUD can be inserted up to within 5 days after the incident, and it's highly effective. It's the most effective. It reduces the risk of pregnancy by more than 99%. But it is invasive, and you got to stick it in. But 10% of women that present for emergency contraception actually would choose the copper IUD if that were an option. So we're actually encouraging ER doctors to get trained and do it there and then if somebody presents, because that's your window of opportunity before they walk away and they change their mind, and then they have another accident. And then we're also encouraging academic centers such as Stanford that has an OB-GYN program. If your ER doc won't do it, call down the OB-GYN. There's always an OB-GYN resident around, eager and ready to do a procedure, I think. So emergency contraception pills. So this is the over-the-counter levonorgestrel only that you might have heard some controversy, and we'll hit that on a different slide. It's a safe and effective backup birth control method, not your plan A, but your plan B, that provides the last chance to prevent pregnancy after contraceptive failure or unprotected intercourse. When might somebody want or need to use emergency contraception pills? The condom broke during sex 4 days ago. So again, you can use it up to 5 days out. I forgot the last 3 days of my birth control pill. I was away, I didn't have the pack, whatever, it's locked in my locker and I'm at home, and I had sex today. I forgot to use spermicidal foam. I went to the bathroom after sex and my NuvaRing fell out, and I didn't have another one because the drug company wouldn't refill it or something. I forgot to get my Depo-Provera shot because you have to go in every 12 to 14 weeks to get that shot, and I just couldn't get into the doctor's office. Primary care offices were jammed or something. Or I was date raped 4 days ago. If somebody comes to you and says, I was date raped 4 days ago, emergency contraception. So the most common side effects are nausea in about 23%, vomiting in 6%, and irregular bleeding. This is high-dose progesterone. Scares the period, and so it messes things up. So this is the controversy you've been hearing about. In 2013, a judge ruled that there should be no age limit per science, per 50-plus medical organizations, per the FDA. Never in our country's history has the HHS overruled the FDA nonpartisan committee. However, Sebelius overruled it and Obama backed it up. So rather than just stand down and say, oh, the judge said we have to send it over the counter, Obama and the Department of Justice and Sebelius say that they will appeal and they will block access to teenagers to prevent teenage pregnancy. The FDA, in trying to mediate between the two, said, all right, we'll approve it right now for 15 and above. So now we're just talking about 14 and 13-year-olds. But it's really the principle, you know, and also what 15-year-old has an ID. So the 15-year-old's going to get emergency contraception. Mom, where's my passport, right? That's their only photo ID. And what percentage of Americans have a passport, right? Supposedly like 17% or something like that. So how's this 15-year-old going to show their ID? So there is no medical or public health reason to limit access for emergency contraception. This will only result in teenagers getting pregnant that don't need to be pregnant.
In sifting through the controversy through the media,
Yes.
I have yet to find exactly what the argument for the Department of Justice and Obama, what they have. Sebelius' argument is very fuzzy to me. And
Yes.
Is there anything?
Their argument is that there is insufficient evidence on the long-term health effects of a 13 or 14-year-old taking this medicine once or twice or 3 times. And again, I say it's obvious to me. Do we have to see teenagers get pregnant, which is going to mess up her brain more, taking this medication once or twice or 3 times, or having an unplanned, unwanted pregnancy? I think it's obvious, and women should not have to suffer and prove this. We're going to do a randomized trial. You get emergency contraception, you don't. You're going to be messed up. You're going to be fine because we're going to prevent pregnancy, right? So that is their thing. They're hand-waving the psychological consequences, blah, blah. But all the research has shown, one of their concerns was if we provide this medication out there, kids will have wild, crazy sex. The research has shown there have been 2 studies out there where we give emergency contraception to one group and we give information to the other. When comparing the 2 groups after 6 months to a year of this group that has it in their hand doesn't say, screw the condom, I don't care about STDs or AIDS, I'm not going to use that anymore. They don't say, oh, I'm on the birth control pill, I'm going to go to Plan B, which is less efficacious and risk pregnancy, screw the birth control pill, or I'm going to suck out my Depo and, you know, rip out my IUD. They don't change their birth control method. They don't increase promiscuity. So they don't have more sexual partners. Oh, I have Plan B, now I'm going to go have wild, crazy sex. And they also aren't at increased risk for STIs. So all of their concerns are unfounded. You can go with this psychological thing, but to me, I don't have to do that study. I know the research. A person with an unplanned, unwanted pregnancy is going to be far more messed up than somebody who had access to prevent that unplanned, unwanted pregnancy. So it does increase emergency contraception use. Obviously, if you have it in hand, you're going to be more likely to use it, and you're going to use it sooner. And so I tell patients you have up to 5 days, but the sooner you take it, the better. It can be taken up to 5 days. It's more effective if it's taken sooner. Levonorgestrel, which is the Plan B over-the-counter, decreases the risk of pregnancy by 89%. And then the old-fashioned method, 4 birth control pills now, 4 birth control pills later, is only 75% effective within 3 days. So this is my favorite graph that I'm a graphic person for my patients, hope to stick it in their mind, is that if you get it within 0 to 12 hours, the incidence of pregnancy is 0.5. If you do the next 12 hours, which is when most people show up morning after, then it's 3 times that rate. So I say every hour you wait, you double your chance of getting pregnancy, because it's kind of an exponential curve in my mind. So I say if the condom pops at 310, I want that medicine in that girl's mouth at 320. I don't want any cuddling, snuggling, waiting till the morning after, waiting for 5 days after, because you heard me say 5 days. I want it in her mouth as soon as possible if you want to prevent pregnancy. If you don't want to prevent pregnancy, just ignore me. But if you do want to prevent pregnancy, get it in that person's mouth. It does not protect against sexually transmitted infections. It's not an abortifacient. This is very important. If you're pregnant, you take this medicine, nothing happens. I love to give this talk when I was pregnant. I'd be like, I'll pop 2 pills right now. Nothing's going to happen to this pregnancy. Progesterone is a hormone of pregnancy. It supports pregnancy. It's sometimes used to treat women who have frequent miscarriages, to help them hold the pregnancy. It's not teratogenic. Again, if I took it and I was pregnant, the baby wouldn't grow an extra arm or leg or turn into a girl or a boy when it wasn't before. It will not affect an existing pregnancy. How does it work? So this is some of the controversy, but it's important that we know the science and not the fiction. It disrupts normal follicular development and maturation. So basically blocks the egg from coming out. If the egg's trying to grow and pop out, boom, not going to happen because we just scared you with a ton of progesterone. It may also interfere with sperm migration, sperm capacitation, and this is the key phrase, that does it affect implantation? Once the egg and sperm hook up, does it block it from sticking to the uterus? Because some very conservative people would find that offensive if we did. The ability of Plan B to interfere with implantation remains speculative, since virtually no evidence supports that mechanism, and some evidence contradicts it. And that's by David Off and Trussell, who are the gods of emergency contraception, in JAMA, which is the Bible of medicine next to NIJM. So that's 2006. Really old data. So anybody who's up to date on their science should understand this has no effect on implantation whatsoever. Educate men about emergency contraception. As I alluded to before, in a heterosexual relationship, who's more likely to see the condom pop? The guy. If I were the guy in the condom pop, I'd be like, 4 out of 5 chance she won't get pregnant, 1 out of 5 chance she will, but there's nothing I can do, right? Wrong. If I know about emergency contraception, I'd be like, where's that emergency contraception? Crap, that condom pop. Or here's a pack of emergency contraception. I heard Dr. Yen talk, or my mother or my grandmother or my cool aunt told me, get a pack of emergency contraception. Because my mantra is, wherever there's a heterosexual male who's being sexually active and doesn't want to impregnate, should have a pack of emergency contraception. Condoms pop, even to the best of us. And then wherever there's a woman, regardless of her orientation, because God forbid she get raped, there should be a pack of emergency contraception on your way to that ER. If you don't want to be impregnated by your rapist baby, you need to take that emergency contraception if you want to prevent it, but it's up to you. So get emergency contraception before you need it, so it will be at hand. It lasts for 2 years. It's $40 to $50. At the end of the 2 years, if it's about to expire, go to a college campus, leave it on the table. Somebody might need it, right? So I love the fire extinguisher analogy. Emergency contraception is like a fire extinguisher. You want it when your house is burning down. You don't want to be like, the condom pop, run to the pharmacy, oh, we don't have it in stock. Oh, I'm an anti-choice, anti-woman, anti-reproductive rights pharmacist that wants you to be impregnated by your rapist, so I'm not going to give you this medicine. You want to deal with that issue before the emergency, not when you're crying and freaking out. IUDs, as I mentioned before, the key contraceptive update, other than you can take your pills and skip the placebos and not have any periods, and we'll hit that on the next couple of slides, is that IUDs are a good thing. They're okay for women who have never had children. So you'll hear the commercials and they'll be like, well, if you've already had 2 children, then think of the IUD, but it's perfectly fine in nulliparous women. And ACOG, the American College of Obstetrics and Gynecology, have said that over and over again. In the past, there was a concern that if you have some foreign body in your uterus, you're at increased risk of having an infection crawl up into your uterus, but it actually does not increase your risk of an infection in your uterus. In your vagina, it's not going to protect anything, but in your uterus, it doesn't increase the risk of an infection in your uterus outside of the 30 days after insertion, because the vagina is a dirty area and then it goes up when you stick it through. And so if you touched any of the vagina as you stuck it through, you might get an infection. But outside the 30 days does not increase your risk of STDs. And that has been a huge concern. And it does not affect your future fertility. A good website for those people considering it, talking about it, I love this website, may be the IUD.org. It's specifically targeted to 20 to 30 somethings. It's neon, it's black, it goes over the pros and cons. And then pictured here is the Mirena Iud, which I think is just magical. It can be used up to 7 years. It decreases the heavy flow in women. It's used to treat dysfunctional uterine bleeding, menorrhagia, bad evil cramps. It's kind of magical. And you just stick it there for 7 years and you can change it. And then the copper IUD is for 12 years. And there we go. So a totally different topic. Is menstruation obsolete? This I thought I chanced upon this while trying to get pregnant and realizing that the only reason I had a period is I didn't get pregnant. The only reason we build that lining and wait for this egg and sperm to hook up is because we're trying to get pregnant. If we're not trying to get pregnant, why are we building this lining and popping out an egg every single month, 1 week out of 4, being used energy like this and life distracted when we don't necessarily need to? But Dr. Coutinho in 1999 produced this great work, as well with Sheldon Segal, who was the founder of Norplant. So there are conditions where you may want to just turn off your periods. People who have exacerbations with their periods, who have asthma, arthritis, depression, diabetes. Some people notice their diabetes get whack according to their periods. If you stabilize your periods and your hormones, things don't go as whack. Neurologic diseases, seizure disorders, menstrual or other migraine headaches that may be exacerbated by your periods. Obvious reasons: quality of life. Environmental: if you have fewer periods, you use less tampons, you use less pads, and therefore you won't make as much an impact on this earth. Financial and educational: dysmenorrhea is the single greatest cause of lost work and school in women under the age of 25. I have some patients present to me and they go, oh, well, my mom lets me miss school 1 or 2 days a month. Out of 20 days, that's 10% of your educational opportunity. The best grade that girl will ever get, A-, B, because she's already lost 10% of her educational opportunity every single month. So it seems small, 1 or 2 days a month, but when you think about it, that's 10% of her educational opportunity. And 10 to 45% of teen women miss school because of dysmenorrhea. Again, I told you my epiphany. And then just looking at, is a young woman who's worried about blood coming out of her uterus or feeling the blood coming out of her uterus or vagina going to be doing as well on the PSAT, SAT as her friend next to her who's not on her period right now? What do you think? Or giving a speech in front of people, or doing a speech and debate competition, or, whatever sport. And if a young woman doesn't intend to get pregnant, why are we building this up, sloughing it, and popping out an egg every single month? So we have ingrained it in young women's heads. You have to have a period every single month. But incessant menstruation hasn't always been the way. If you look at Dr. Beverly Strassman, who studied the, excuse my pronunciations because I don't know how to really pronounce these, doggone tribe of Mali in Africa, she went to the menstruation hut, observed for 736 nights. That menarche for them was 16. In the United States, 12.5. They gave birth 8 to 9 times. Not saying we should go there, but in the United States, we give it like 2. And they breastfeed for 15 plus months, 2 years. We do like 6 months if we're good. They had 100 menses in their lifetime, and they died at 60 to 70. So we're not comparing like people who died at 30 to us. We're comparing people who died approximately the same age. We have 350 to 400 menses in our lifetimes, 3 to 4 times the amount of periods that they have. And we have endometrial cancer, and we have ovarian cancer. Why? Because we're building, sloughing, popping that we don't need to be doing. So graphically, just to look at this, because I like graphs, is under the area curve is the American number of periods, and under this area of curve would be the African number of periods, so far fewer. And again, emphasizing you really don't need to do this exercise unless you're trying to get pregnant. Menarche, again, 12.6. First birth in the United States, 26. 13 years of a period every single month for no good reason. So it's a difficult concept to convey, but I think you're all very educated people that not having a period if you're on the pill, the patch, the ring, or the IUD, Mirena, is perfectly fine. If you aren't on none of those methods, then we need to talk about why you're not having a period every single month in the United States, because it may be anorexia, it may be stress, it may be bulimia, maybe other hormonal issues. And then just for those of you on the pill, patch, ring, it's perfectly fine to skip that week. That week was just made up by Dr. Rock because he was a good Catholic and he realized that the rhythm method was perfectly fine. So if he could make the period come regularly, then you could perfect the rhythm method. And the church almost voted yes on that, but unfortunately Pope Pius XIV got wind of it and said no. But a great article to read that covers the incessant menstruation and the not necessarily the need to have a period every single month is Malcolm Gladwell, John Rock's Error, in March 2000. You can Google it, it's online. It's a great article to allay your fears about turning off periods. And that's just comparing a physiological cycle, and if you just continue on birth control pills and skip the placebo, it's perfectly fine. And that's it.
The new smaller IUD, is that just like a marketing gimmick?
Pretty much. There's a new IUD. Dr. Jacobson may know the name. It's eluding my mind right now. but it's just a marketing thing because you actually have your periods more regularly on that, which some women may treasure, but I like the whole turn on, lose your period kind of thing. And it is smaller, so they're trying to push it for the nulliparous women, but it only lasts for 3 years, I think, and so why not stick in something that's 7 years and has a chance of getting rid of your periods versus something that will only last 3 years, and most things are 4 years. College is 4 years, med school is 4 years, law school is 3 years. Why would you not do the 7 year that would cover you through college and med school, right? So I really think it's a marketing thing.
I've heard 5 years for Mirena.
So 5 years is what the on-label says, but the research and the people who follow Contraceptive Update, which is like the Bible of birth control, is 7 years. So to maximize your bang for buck, but you could change it at 5 years. And same thing for the copper IUD, technically 10 years, but Contraceptive Update and people who practice according to that, and the research is there, is 12 years.
So I've heard that IUDs are the most common worldwide,
Yes.
and seem to be kind of a no-brainer. What's the history of why in the States, everybody I know my age is on them?
It's because the Dalcon Shield was in the United States and did very bad things to a lot of women. I don't think they did the research before they released it, so it was an IUD. Dalcon Shield was an IUD and it looked like a cockroach or something. And it stuck to your uterus and it did bad things. And so the people have bad taste in their mouth from the Dalcon Shield. But now we're waking up to the science and the data and catching up with the rest of the world.
Are insurance companies paying for contraception like that?
Thanks to Obamacare, all FDA-approved birth control is available with no copay.
Thank you, Dr. Yen. All right, now I get to talk about surgical management of fibroids, 50 slides in 15 minutes. So I'm going to review the definition and epidemiology of fibroids and talk really about surgical options of fibroid management as of today. I have no disclosures. Fibroids, leiomyomata, they're smooth muscle cell tumors of the uterus that are almost always benign, okay? So cancer of muscle of the uterus is called a leiomyosarcoma. It's much less common. It's about 1 in 500. Fibroids affect up to 70 to 80% of women, but only 30% of these women are symptomatic, okay? So if you have a fibroid, it doesn't mean you have to do anything about it. They occur in the greatest prevalence in the 5th decade of life. For some reason, African Americans develop fibroids earlier than non-African American women, and they have surgeries more often. Fibroids rarely occur before menarche. And once you hit menopause, I call it crossing the finish line because then they shrink. And they're usually not problematic unless you're on menopausal hormone therapy that's systemic, and that makes stimulate growth of the fibroids. Direct health care costs in the United States are up to $2.1 billion annually. They're the leading cause of hysterectomy, so 200,000 hysterectomies are performed for fibroids in the United States each year. Symptoms, as some of you know, include heavy menstrual bleeding, which may lead to anemia, pelvic pressure, pelvic pain, pain with menses or dysmenorrhea that Dr. Yen talked about before, bladder dysfunction, urinary frequency, bowel dysfunction, basically from compression on the bowel. Some women may talk about constipation, infertility sometimes, and no symptoms at all. So there are very few comparative studies that look at fibroid treatment options. So it's really hard to compare one procedure with the next. But you really have to take into consideration the safety of the procedure, the effectiveness, the woman's desire to conserve her uterus, whether it's because it's her organ and she wants to keep it, or because she wants to be able to get pregnant and carry a pregnancy in the future. Traditionally, treatment has been focused on surgery, specifically myomectomy, removing the fibroids, or hysterectomy, removing the uterus. In terms of medical treatment, we don't really have any long-term medical treatment. The medical treatments that we have now really focus on shrinkage of the fibroids, which may help with the approach that you'll use surgically for removal of the uterus or fibroids, or you may want to build up a woman's blood cell count prior to surgery to decrease her risk of a blood transfusion. Thirdly, if a woman's in the perimenopausal years, so she's having, a few periods a year, she's around 50, and she's having problems with fibroids, you may be able to use one of these medications, or actually either of these medications, to bridge her into menopause. So it won't hasten menopause, but it may suppress her periods, so hopefully at the end of that treatment interval, she'll be able to transition into menopause and dodge the surgical bullet, so to speak. So the two types of treatments that we have in existence now are Gnrh agonists, also known as Lupron. That's the most common one. It's an injectable form of medication, either a monthly injection or a 3-month injection. It's also used to treat other disease processes, such as prostate cancer in men, obviously, as well as endometriosis. They're also Gnrh antagonists. Ulipristal acetate, Dr. Yen talked about with respect to emergency contraception, and the trade name for that is Ella, but it's also been studied in Europe with respect to shrinkage of fibroids, decreasing heavy menstrual bleeding in women. However, the data with respect to fibroid treatment with this is very limited. The studies I saw in the New England Journal of Medicine from last February of 2012 showed limited safety and efficacy. Not as much of a shrinkage of fibroids compared to Lupron, but less adverse effects. So Lupron depletes you of estrogen and progesterone, so that can cause hot flashes, night sweats, mood swings, vaginal dryness, as well as bone loss. So that's why you cannot be on Lupron for 6 months unopposed, or maybe up to 12 months with estrogen or estrogen and progesterone replacement therapy. Anyway, so I would keep your eye on this ulipristal acetate, because that may be an up-and-coming medical treatment for fibroids, but still there's some things that are concerning, meaning what is the effect on the endometrial lining with this type of drug? This drug is a progesterone receptor modulator. So there's a concern that it can stimulate the endometrium and cause proliferation and may increase the risk of endometrial cancer. So now we're going to zip to invasive procedures. I'm going to mention all of these actually. Hysterectomy, hyster is uterus, removal of the uterus. It may or may not include removal of the ovaries and fallopian tubes. And preservation of the ovaries is a whole nother lecture. Still a very common procedure in the United States, even though we have alternative therapies for heavy menstrual bleeding and fibroid treatment specifically. Over half of hysterectomies in the United States are done in women under 44 years of age. There are different ways to do a hysterectomy. This is abdominal hysterectomy, so the woman has basically, a bikini cut like a C-section or an up and down incision. And this is a fibroid uterus, the irregular shape. Vaginal hysterectomy isn't performed that often for fibroids because the uterus can be so big you cannot remove it vaginally. I couldn't even find a photograph, but anyway, so you're operating through, a little keyhole basically of a speculum in the vagina, and this clamp is on the cervix, and this clamp here is getting the blood vessels along that lateral aspect of the uterus. And then we remove the specimen through the vagina and then sew up the vaginal cuff that way. This is a great procedure because women recover the fastest out of all the different procedures, and it's the most cost-effective procedure. There's also laparoscopic hysterectomy, so through small incisions. It can be from 3 to 5 incisions. Some surgeons are doing it single port, so just one incision. And so this is the fibroid uterus, and these are the laparoscopic instruments. So you get to the blood supply from above, and you can either hopefully get the specimen through the vagina. You may have to bivalve it or core it in order to get it through the vagina, and then sew up the vaginal cuff. Myomectomy has been the gold standard for treatment of fibroids in women who want to preserve fertility or, like I mentioned, preserve their uterus. The procedure is really dependent upon the size of the fibroids, the location of the fibroids, the number of fibroids, and the patient's desire for future fertility. And again, I should also add for uterine preservation, even if women are not interested in future fertility. This is a cartoon of fibroids. So this is a coronal view of the uterus. This is the cervix and the vagina. The fibroids start from the thick muscle of the uterus, the myometrium, and then they can push into the endometrium, and that's a submucosal fibroid. That can cause heavy menstrual bleeding and anemia. This is another submucosal fibroid there. They can push out here. This is on the right side of the patient, and this is called the subserosal fibroid. But these can wreak havoc in terms of the bleeding. Also, they can impair your ability to get pregnant, and they increase the risk of a miscarriage. That's specifically the submucosal fibroids. So this is a hysteroscopic view of fibroids. I don't know if we can dim the lights, but basically the woman's under some sort of anesthesia. She can be under conscious sedation or general anesthesia. The speculum's in the vagina. We're dilated the cervix. We go in with a hysteroscope. It has a lens at the end of it. We distend the uterus with fluid, with salt water or some other non-energy producing source, and then we resect these fibroids with a hot wire, basically, called a loop electrode, or mechanically we can suction or vacuum out the fibroids under direct visualization. So this is no incision. We can only resect what we can see. So if I did a hysteroscopy, I could only see in the uterine cavity, so I could remove that one and maybe part of that one, maybe not the whole thing, because I can only see this part here. That's bulging into the uterine cavity. So that's a great procedure for specific patients. Usually you can remove it, fibroids hysteroscopically up to 4 to 5 centimeters, but it does depend upon the surgeon's level of expertise. Endometrial ablation is basically burning the superficial surface of the endometrium, and you can actually treat fibroids up to 3 centimeters in diameter with certain types of endometrial ablation devices. So again, the speculum's in the vagina. You pass this catheter into the uterine cavity, and for this one, basically you open up a fan, and it heats up to a certain energy, and it basically burns the tissue and hopefully just necroses the fibroid. Minimally invasive surgery, I already talked about. I only have 5 minutes left, so I'm going to zip through this. But there's laparoscopic and robotic assisted laparoscopic myomectomy. So again, you're operating through small incisions. The benefit of laparoscopy or minimally invasive surgery in general, we can actually see better because the optics are better than your eyes, so everything's magnified. You have more eyes looking in the room because everyone's looking at the monitor, so hopefully it's safer that way. There's less blood loss. There's a shorter stay in the hospital, so you can be out the door that day or the next day. Your recovery's faster. There's less scarring, less risk of infection, usually less pain and improved cosmesis. Compared to, this is a fan and steel incision, so that's the bikini cut for the C-section. And this just talks about laparoscopic surgery. Robotic surgery, basically, I guess I deleted that slide. So the only advantage to robotic surgery, in my opinion, with respect to myomectomies, is that it's easier to suture, but that has its issues that I'll talk about in about 30 seconds. So with myomectomy, obviously one of the long-term concerns is recurrence of fibroids. So if I have a patient who wants to get pregnant, but she's thinking about 3 years or she's not ready yet, and she has fibroids and isn't really symptomatic, I'm going to be reluctant to operate on her because she could have recurrence and then need another surgery before she's ready to start trying to get pregnant. So anyway, so that's something that you have to consider. And also, with respect to myomectomies, once you have fibroids removed, especially abdominally, you may end up having a cesarean section scheduled because of concern about your uterus rupturing in labor, okay? So that is somewhat subjective, but it depends upon the size of the fibroid or fibroids that are removed and how deep it penetrates into the myometrium. There's another controversial issue about basically having a myomectomy laparoscopically and then laparoscopic suturing of the uterus and then going on to be pregnant. So a patient who had laparoscopic suturing, I would be more inclined to recommend a C-section because you're worried about the uterus rupturing the 3rd trimester of pregnancy even before labor. Okay, there are case reports on that. It's really hard to study because people aren't going to want a randomized study to, answer this question. Fibroid embolization is done by interventional radiologists. You're under conscious sedation, so intravenous line. You have IV Versed and fentanyl. They make an incision in your right groin. They thread catheters from the femoral vessels to the uterine vessels, inject synthetic substance, polyvinyl acrylic beads or gel foam into the uterine vessels to decrease blood flow to the fibroids. So the fibroids are supplied by blood vessels that are end blood vessels, so there's no collateral blood flow to the blood vessels. As opposed to the uterus, there's collateral blood flow to that. So the uterus isn't getting necrosed with that uterine fibroid embolization. But the idea is to cut off the blood flow to the fibroids and to shrink the fibroids with this procedure. This is an angiogram. It's not showing up well, but all these dark lines are all blood vessels, and the white is supposed to represent the size of the fibroid. This is pre-embolization and post-embolization. You see all those blood vessels went away. and they haven't gotten looks like the left uterine artery yet on this angiogram. And this fibroid, it was 14 centimeters pre-embolization, then it was shrunk down to 11 centimeters 3 months afterwards. So the fibroid embolization shrinks the fibroids but doesn't make them go away. So the benefits of fibroid embolization are shorter procedure length, less likelihood of a blood transfusion, shorter hospital stay, less time to resumption of routine activities. But the problem is with fibroid embolization, there's a higher rate of reoperation, okay? There's like a 5 times higher rate of reoperation compared to myomectomy and hysterectomy. So you have to choose, I don't want to say choose the patients well because I don't want to be paternalistic, but you have to work together with the patient, the interventional radiologist, and the gynecologist for what's best for you. What about fibroid embolization and future pregnancy? I wouldn't recommend it, but it really is not an absolute contraindication. Studies have shown term pregnancies without a problem after fibroid embolization, but other pregnancies, there's one study that shows the uterus rupturing after fibroid embolization in pregnancy. And also women, there's a 3% chance of going into earlier menopause because of the diminishment of the blood flow to the ovaries from the synthetic substance I told you about. I'm going to zip through to the MR, imaging guided focused ultrasound. This is approved by the FDA in 2004. And basically, this only can treat 10% of fibroids with a rate of 60 to 70% long-term symptom relief. So I think that's a pretty high failure rate. This is a woman who's going to undergo this procedure. She's lying in an MRI tube. She could be in that tube for 3 or whatever hours having this done. And you see the transducer, she's lying on her abdomen. The transducer is touching here, and it's positioned based on the MR where the fibroids are. So it's ultrasound energy that's going through her skin deep to the tissue of the fibroids. So again, to me, a 35% success rate isn't that great. I'm not a big fan of that. The last thing I want to talk about is radiofrequency thermal ablation, and this is just a different form of energy that can be used either through the abdomen, so with needles or catheters through the abdomen, putting a speculum in the vagina, or through the cervix. The latter two are not approved by the FDA in the United States. But basically the technology is it heats up the fibroid and can basically kill it off. But the fibroid shrinks. Again, it doesn't go away. The laparoscopic radiofrequency ablation system, this was approved by the FDA in November of 2012. But I'll caution you with respect to these medical devices because very little data needs to be proven for the FDA to approve these procedures. You have to just watch this with a jaundiced eye. So this study only had 300 women in it, and all it proved was that it was safe and effective. But that was it, and that was only after a 3-month period of time. Remember, it's still laparoscopy. You're under general anesthesia. You're getting 3 incisions with instruments into your abdomen. So I would not consider this a non-invasive approach. This is a cartoon of the procedure, so 3 more slides and then I'll stop. I'm sorry about that. So basically, a woman has an incision in her belly button. Let's say it's about a 1/2 of an inch to an inch where the laparoscope goes, and she has this incision above the pubic bone, and that's about a 1/2 of an inch. And then a laparoscopic ultrasound probe goes through the one above the pubic bone and identifies exactly where the fibroids are and the depth of the fibroids in the uterine tissue. Once that is achieved, then another little, like a 1/4 inch incision is made around the umbilicus, and this probe is put through, and then put right through the uterine wall from this outside into the fibroid, and basically the surgeon hits a button, and then this type of radiofrequency energy melts the fibroid and shrinks it over a course of a period of time. Again, this just got approved in November of 2012. I would be very reluctant to jump all over this technology. So basically, last slide, the bottom line is it's a discussion with the patient, the gynecologist, possibly the interventional radiologist about the best approach to treat your fibroids. Just because you have fibroids don't mean they need to be treated. It's very, very rare to have a leiomyosarcoma or a cancer of the fibroid. So I thank you for your attention. I'm sorry I'm ending a few minutes late. If anyone has any questions, they can just come up to me afterwards. I don't want to keep you guys. So thank you very much.